Talk this morning, and I thank you for taking the time and listening to the excellent talk that Ian and Kevin have already given. And I'm going to discuss in the next 45-50 minutes some of the implications of NPS for the eye. And as usual, please feel free to interrupt and ask questions. If you need to throw a shoe or something, it's been done before. So. But you answer certainly others. All right. Okay, so basically the talk will just cover some of the basic anatomy and physiology of the eye, which I apologize to those who have been coming to these conferences. This is going to sound redundant, but you never can get too much eye anatomy, I've always said. So, and also to summarize the ocular findings in NPS I mentioned, particularly citing some of the studies that you already heard about. Let me just make sure. Here we are. From Elizabeth Sweeney and Lampkin, a study in Pittsburgh, and also discuss the most critical aspect of what NPS does in the eye, particularly related to glaucoma. Okay, and that's the part that we're going to spend some time on, and I know afterwards we're going to meet one-on-one and discuss how, if you have glaucoma or are being adequately screened for this condition. Okay, so very simple diagram of the eye. Here is the front of the eye, there's the eyelids and the back of the eye. The cornea is the first layer that one encounters, particularly as you're seeing anything. The first layer that the images, the light rays from the images enters the eye is through the cornea. And there's a chamber here called the anterior chamber, and that's a space between the cornea and the colored part, which is the iris. And when you're looking straight on, that's the iris. And often people say, well, I got so-and-so on my iris. What they're really saying is that metallic foreign body or what have you is on the cornea, but it just happens to be in the area where the iris is beneath. Then there's the lens, just like in a camera, which focuses. And that lens is suspended with tiny thin guy wires. And the focusing mechanism is very interesting, and I'll show you on the next slide how the eye focuses. It's very interesting. And then the sclera is the white part. So the white part that you see is deep to the conjunctiva. There's a very loose layer, transparent, called the conjunctiva. That's when you get conjunctivitis. It gets red, swollen. And then beneath it, there's another layer, but you don't need to worry about it, called tenons. But beneath that is a tough sclera. And it's a tough layer, actually. And then there's a cavity in here full of a gel. And when you and I were 8 years and younger, that's a very solid ball of gel. And as we get older, or if you have other conditions like diabetes, or you're extremely nearsighted, over time that gel turns to liquid, and there's little pockets that form like Swiss cheese. Doesn't taste like Swiss cheese, not the ones I've had anyways. But it eventually liquefies, and you have a central core of water and a thin rim of jelly, and at some point in all of us it implodes. And during that process of implosion is when you can start seeing a lot of floaters or flashes of light, and in some cases it leads to retinal detachments, which is how I make my living. Then the cable that connects the eye is continuous with the retina. You see, so the retina is the inner lining, it's the film in the camera, and it has 1.5 million nerve fibers that come through an area that's just a little over 1.2 millimeters, 1.3 millimeters, and it goes to the brain. Here is a detailed, blown-up view of the part that's going to be important for you and I in discussing glaucoma. This is a cross-section of the front of the eye. Here's the cornea in layers, and there's a bunch of layers. Here is the iris in cross-section. Remember the guy wires I told you that hold this lens? So when you and I read something up close, this muscle, imagine it's like a ring, like a trampoline. The trampoline has this metal ring, and then there's coils to this member, to the stretchy part. If I was to imagine this lens is elastic, if I was to shrink that ring, this lens gets fatter. When it gets fatter, it gets more powerful. So when you and I do this, this ring which goes around the eye constricts. And when it constricts, the lens gets stronger and fatter. When you look far away, it relaxes. And because it's under tension, when it relaxes, it stretches back to its normal position and makes the lens flatter. And therefore, you're focusing for far away objects. But if you look at the corner, or what we call the angle, you're going to remember that name because you're going to hear it from your ophthalmologist, the angle that is made by the cornea and the iris, okay? If that angle is open, that's a good sign. If it's closed or narrow, that can be normal, but sometimes it can lead into problems in a different type of glaucoma, and I'll discuss that in detail. But just remember the structure. Now, what's important about the angle? There is the grate, the meshwork, for where the water that you and I produce in our eye to keep our eye inflated like a soccer ball, instead of air, it uses water. And this structure here, called the ciliary body, has two functions. It is anchoring the guide wires for focusing, but it also secretes a drop of clear water that's filtered, very similar to what Kevin talked about, and that's why he said the kidney is the seat of the soul, which he's right, but the eyes are the window to that seat of the soul. But there's a lot of very similar appearance of the structures in the eye that share with the same as what Kevin was talking about for the kidney on the cellular level. And as a matter of fact, when I first started my fellowship in San Francisco in '91, the nephrologist would often come and discuss in detail the patient's retinal situation, because that was actually a very good predictor of how the renal function was, at least visible, and it's vice versa. So it's easier, to look in and do a fluorescein angiogram and kind of get said, this is what the capillary bed looks like in the eye. You can bank your bottom dollar, the kidney's not too far behind. So that also extends on a molecular level to this structure here, the meshwork, because it's not the same, but similar layering of cells, and cells that kind of protect cavities and spaces and so forth. Now, it's not an intricate filter like the kidney, it's just a very passive filter to some degree. So it's like a grate. And the best analogy I can give you is if you look at your blinds at home, those of you that open the veins of the blind to enclose, that's how this structure really works with these muscles. So when some of the medications that we use, like the old medications like pilocarpine for treating glaucoma, would kind of pull these open, okay? And others would not affect that, but reduce the output of that water. So there's a bunch of things that it's good to have this in mind when you discuss the treatment of glaucoma as well. This is a schematic to show you what I just mentioned, so illustrating. Here is the ciliary body. That's the pump that produces that clear water. It circulates, 85% of it circulates this way. There's a little bit that goes into the gel and nourishes the retina a little bit, but that's a very small portion. The vast majority goes around the lens, behind the iris, squeezes around here, and drains in the front, that trabecular meshwork, okay? And then it goes into your venous system, goes back to the heart, and so on and so on, okay? So remember this, because you interrupt that for any means, that pressure gets jacked up. Pressure gets jacked up, and the damage happens to the optic nerve, okay? So when your clinician looks in, okay, what do they see is, at least when they're looking at you primarily for glaucoma, they're looking at that nerve, okay? If you remember this structure here, remember the nerve that comes in here? When you're looking at it head on, okay, this is what you see. You see a donut. Okay, think of it as a donut. You have an outer diameter and an inner diameter. And clinicians conveniently divide what they call the cup to disc ratio. Because if you look at it in 3-dimension, and I'll show you an illustration, we all have a cup. Well, 99% of us have cups. So it's not abnormal to have a cup. The question is, how wide and deep is that cup relative to the optic nerve? And the other analogy that's important to remember is a beach ball. You know, those nice little cheap beach balls that we seem to get at the dollar stores a lot. They have the valve, and you blow it up, and then if it's a good beach ball, you can tuck the valve in so it's not sticking out. Why? The eye is very similar to that. The weak spot is the optic nerve. So if you have a high pressure, the first area it's going to push out is right in the center of the optic nerve. It's soft tissue. And when it does that, it starts to crush those slowly. I'm giving you a simplified version. It actually doesn't crush. There's a process called apoptosis, which may or may not get covered, but it's a way of destroying a patterned destruction of the nerves. Okay? So this is the physiological cup. Is again physiologic, meaning it's normal to have a cup, and generally as long as the inner diameter, if you divide it by the outer diameter, is less than 0.5. So in other words, that inner diameter shouldn't be more than 50%. Now, there are millions of people who have, instead of 0.5, have 0.7 cups, never get glaucoma. They have perfectly normal visions. Okay? That's called physiological cupping. Now, the other way is not so true. You're not going to get somebody who has a normal cup and, more importantly, a normal rim and have glaucoma or glaucomatous nerve damage. It's much more common the other way. Okay, so if you have more prominent cupping, yes, there is a higher chance that you're going to get glaucoma, but it's not 100%. Okay. So what are the findings and then ocular findings, the eye findings in NPS? Here's a list of conditions, and I'll quickly go through them. Strabismus, when your eyes are not aligned, just like our car tires, we need to go get them aligned. The same thing is strabismus. Ptosis, the drooping of the eyelid. Actually, it should be blepharoptosis, because you can have abdominal ptosis, but that's common here. Speaker, but it's different. Hypertelorism, okay, separation of the eye. They can be aligned, but they're wider set apart. Epicanthus is folds around the inside of the eyelid, and I'll show you guys. Sclerocornea, keratocornis, microcornea are all abnormalities of the cornea itself, and I'll show you a little bit of examples of those. Aniridia, it's interesting. Kevin knows about aniridia very well, but it's a rare, fortunately very rare condition, and has renal, major renal abnormalities, but it is with the absence of the iris, or actually very little tissue of the iris. Okay, so these people have clinically have problems seeing bright light, because what you and I use our iris for is to restrict the light input, and one of the functions. Anisocoria, meaning the pupil sizes are unequal. So one pupil is wider or larger diameter than the other. Heterochromia, meaning the pupils are the iris is, there's a slight difference in the coloration between the right and left eye, for example, okay, or patches of the eye. Glaucoma, of course, is the biggie. Cataracts, microphakia, meaning a small lens. Now, I caution you, and as probably as speakers have mentioned to you, when you have a rare condition like NPS, initial reports tend to say, you know, having a big toe is sine qua non or illustrative of this condition. In fact, as they accrue more samples, and people say, well, big toe is not really associated with this. And probably the same situation arises with the eye findings. Okay, a good example is iris pigmentation, or Lester's sign. Okay, remember, some of you have been here in the past. This sign, and I'll show you a slide, was said, oh, yeah, if you've got Lester's sign, that's a high probability that you've got NPS. Well, as time goes on, it's not as tightly associated. Okay. So here's a good illustration of Lester's sign. It's a clover leaf-shaped dark pigmentation on the pupillary margin. What I mean by pathognomic, it's not pathognomic, meaning if you have it, it doesn't mean that you have NPS definitively. Okay. It is a normal variant and found only about 42%, and this is on average, because both the studies that I'm referencing, Elizabeth Sweeney found it in 54%. And 35% in Pittsburgh, we found that sign. And here's an illustration. It's kind of the scalloped margin of the iris pigmentation, okay? And so it's distinctive when it's there, but again, it's not, if you have it, that's it. You have NPS. Or if you don't have it, you don't have NPS. Okay, glaucoma. That's the one I'm going to spend the bulk. Any questions so far, by the way, on this? Yes?
So, you could go back to
sure.
One more.
Yeah.
So when you say findings in NPS, these items, more prevalent in NPS, or they are findings in NPS just the rest of the population?
That's an excellent question. It is, based on the current literature that we have, they've been reported as associations slightly more than you'd see in the average non-NPS population. That's probably the easiest thing that we can state about ocular findings in that. Now, How hard are you going to hang your hat, for example, on, aniridia? Statistically, to do this, probably that list will be cut down to a quarter of what it is, probably over time, as we get more and more data. A statistician would definitely cut this to pieces, as I suspect a lot of articles, because it's such a rare condition. I understand the author's desire to say, alert the medical community, saying, okay, we saw a little bit more than usual of these conditions, but again, the sample size is always going to be small. And over time, years and years, as we build up the database, that's why these meetings and getting together and collaborating is critical. You start to say, well, this is not as common, really. Yeah.
So we hear about glaucoma more often than the rest of them.
Right.
I have.
Yes.
So does that mean glaucoma is more prominent?
It is.
Significant?
That we can definitively say it is. And more importantly, say it was maybe 1.5 times more common in MPS. Of all these conditions, the one that's going to blind you the quickest is glaucoma. So it's significant because of what the clinical outcome can be. It's like, for example, as you know, the iliac crest. Well, iliac crest is fine. It's an interesting finding. Very little of clinical consequence for the patient. This is not, though. Cataracts we can treat. A lot of these we can manage, and they're not clinically debilitating. But glaucoma is the #1 killer ophthalmoscopy.
So it's the #1 killer. But
Right.
My question is something else.
Yeah.
Is it statistically more significant than the rest of them? Or is it glaucoma I'm talking about? Or is it
No, it's a good question. I don't know if I can definitively say it because we don't have an epidemiological study enough to do that, but it would be in the top third of the conditions. Let's say we have accrued 10,000 NPS patients 100 years from now, and we look, and we find that half this list kind of drops out, but there's still some of these conditions. Glaucoma would 90% chance be in at least the top in terms of the incidence of it compared to these other things. Because if you look even in the general population, there are common and not so common things. So hypertelorism is rare. Strabismustosis is common. Aniridia extremely rare. Anisocoria somewhere in the middle. Cataracts very, very common. And actually, if you're a statistician, to actually sign off on a study to look at the incidence of cataracts in, say, NPS, the number would have to be huge, and the age range would have to be of such that you could find. It's not going to be an easy study to do unless you focus on pediatric. If you did say, for example, okay, I'm going to round up all the NPS kids that on the planet, and then look at the cataracts, you probably can do the study very legitimately and have a very strong statistical significance or power for doing the study. But I would still say like glaucoma would be in the top third of this list. Excellent question. Any others? And that's why I'm going to spend the bulk of the talk on glaucoma. So what's the definition of glaucoma? This is our standard mantra. Multifactorial, emphasize multi, optic neuropathy. Okay, it's not a pressure issue. It's not. It's an optic nerve disease, if you will, in which there's a characteristic acquired loss of optic nerve fibers. So there's a lot of conditions that can damage your optic nerve, right? You can get a stroke to the nerve, you can get trauma to the nerve, but in glaucoma, it's a certain pattern. Remember I told you about how the crush of that, as the pressure pushes, it crushes the nerves in a certain way. There's a pattern on the visual field testing, which I'll review, that says, aha, this is glaucoma. This is not ischemic optic neuropathy or Leber's or any of the other conditions. The circulation to that little nerve, okay, is pretty intricate. Whenever there's a critical part in you and I, the body generates usually 2 blood supplies because it doesn't want to get stuck. That includes the brain, unless you're a congressman or senator, but we won't go into that now. That's right, or an executive branch, but anyways, you have a dual supply. You have a supply The way the artery and vein enter and exit your eyeball and my eyeball is actually through that optic nerve. Simple reason. You already have a weak opening, and embryologically, as you and I are forming, the important structures kind of get, we call it invagination, but it kind of gets included in that cleft and then finally seals. So if I got an opening, just like a conduit at home, I'm going to run a bunch of stuff through it, and including not only the nerves, but the main blood vessels to the inner supply of the retina. The retina, per weight, is the most metabolically active tissue in the human body, including any parts of the brain. It's only about 1 millimeter thick, and it has a dual blood supply. And one supply comes through the middle, which also nourishes the optic nerve, and also has these penetrating branches all along this nerve at this junction. Okay? Remember I told you about the trabecular meshwork is like the Venetian blinds, open nose? Well, guess what else works like that? Is the cribriform plate. Remember the 1.5 million nerves that come through that little 1.5 millimeter area? They go through conduits. But the conduits, unfortunately, or fortunately, are made of plates. So imagine you have a series of plates with holes on them. And when you and I are born, they're aligned very nicely. Okay? But imagine if I start to push, and I say you have a dozen plates, okay? They start to get, what happened? They start to spread apart. So what happens is these two circles that were perfectly aligned, they start to pull. And so what you start to shear the axons, the nerve fibers. So the more you push, the more that the eye enlarges, the more they garrote each other. They kind of start cutting and shearing at the nerves. Does that make sense to you? Yeah. Okay? So if I have a tunnel made out of a series of little plates with the holes aligned, if I start shifting those plates, it starts to cut off those nerves. And that is the mechanical concept of how a glaucomatous eye damages those nerve fibers. And it do so in a certain pattern, okay? Starting from the outside in a certain pattern. Here is a actual cross-section showing you these axons, okay, and the myelin, the insulation around it. Here's the blood vessel in cross-section that's coming through that will ultimately nourish. And not much of a cup. Now here is the cross-section of a glaucomatous patient. And you see that cupping, we call it, sometimes they call it a bean pot. Because, some of the old days, the bean pots, they had those big belly. And that is a bad sign, because that tells that the pressure has been on there for quite a while. Here is a typical prominently cupped nerve. Now remember, it's not just the cup that the clinician assesses, it's actually the rim. Because the cup is just a space, but what they want to see is that donut healthy. If this is a pale yellow instead of being a nice deep orange, that's a bad sign. That means that the nerves are getting really, really crushed. And what you're seeing here, this yellow structure, is actually those plates. Remember I told you the cribriform plate? The nerves have been worn away so far that you can now start to see the openings of these plates. So, you can tell when I got this slide from, huh? Anyways, this is a patient, this is what the patient experiences who has glaucoma. They have a full visual field. Okay, this is, year one. Suddenly, or not suddenly, progressively, the visual field starts to get closed in, and you see less and less of the side vision until you get tunnel vision. And it's not unusual to have 20/20 vision, but legally blind, because all you have left is just a very small tunnel which these patients can see. That is the typical pattern that glaucoma, regardless of its NPS or whatever, damages your visual field permanently. How do we classify glaucoma in general? Open angle, which is the majority. Remember that angle? So open if it's wide open. Closed angle if it's fused, usually from trauma. When people get hit in the eye or something, the blood and the scar tissue actually zips up that angle. We call it zipping the angle. Congenital is defined as if it's occurring within the first year of life. Juvenile if it's 3 years to early adulthood. It's a less common form, thankfully. And also primary versus secondary. So in other words, primary means it had just already appeared, intrinsic to, like NPS would be a good situation where it's a primary type of glaucoma. Secondary is if they've had cataract surgery or they've had trauma, as I mentioned to you, or an infection that led to scarring. That would be secondary to something, okay? So chronic open-angle glaucoma is the most common one that we're going to be talking about, okay? Now there's variations too. You'll hear about normal tension glaucoma. The pressure, and I'll discuss this a little bit later, the pressure, normal pressure in a human is 10 to 22 millimeters mercury. Okay? That's the normal pressure range. There are people who are walking around, who I've seen for decades, who have 26 pressure, never get glaucoma, right? So their nerves are a little stronger. There are, by contrast, patients who have 11 and 12 millimeters mercury who get glaucoma. So it's all relative. It's depending on how strong that the optic nerve is to handle a given pressure. Okay? So please keep that in mind. So one of the ways we examine, is the angle. There's ways to examine the angle to see if it's open or closed. In pediatrics and in young or congenital glaucoma, the eye is so stretchy that if they've already had high pressure in the uterus or very shortly after birth, they get this big, dark eyes. And since Kevin has mentioned, the nephrologists have almost coined the market on Greek terminology, buphophthalamus, B-U-P-H-T-H, which means ox eye, because when they looked at him, and even in ancient times, they would see these kids born and they would be very sensitive to light because the cornea is often edematous, meaning it's weeping when they come out, and so the light causes a dazzle and they react to that. So they're always either crying or tearing, and they've got these very large corneas and irises. The remarkable thing, though, of all the conditions, they can reverse, if you correct the condition fairly early, you can reverse a lot of this. You won't eliminate it, but you can reverse it because there's so much elasticity in youth. In you and I, we don't have that luxury. All right. This is just the statistics, and I'm going to probably start zipping through this to get to the juicy parts, but it's a significant condition, both US-wide and worldwide. Okay? The prevalence of in NPS of glaucoma, POEG is primary open-angle glaucoma. Okay? So Elizabeth in her study found 9.6%. OHT is ocular hypertension. Now, what is ocular hypertension? Is the patient that walks into your practice with a pressure of 24, 25 or higher, but doesn't have optic nerve issues and doesn't have glaucoma, the visual field is normal, et cetera, et cetera. So there's millions of those people walking around who are OHT, ocular hypertensives. Okay? So she found 9.6, 7.2%. Okay? Now, if you looked at the younger, anybody younger than 40, the prevalence of primary open angle shot up to 16.7%, and ocular hypertension 11.9. So this shot up. If you look at the mean age of primary open angle glaucoma or OHT at diagnosis, it was around 47, say, late 40s. There was a wide range. The presence of primary open angle glaucoma in those over 40 is pretty significant, 30%. Pardon me? You're 17.
I was 17, yeah.
When you're diagnosed. And then obviously MS. And that's the question that was posed earlier was excellent, that is it a true, unlike the other things that have been mentioned? Well, from these studies shows that, yeah, 30% is a pretty high number. Any condition is a pretty high number. You look at the Pittsburgh study. Yes, I'll race through this. Okay. The prevalence of primary open angle is 17.8. Okay, prevalence of ocular hypertension, 8.9. If you narrow it down by the age group, just like Elizabeth did, not as bad. But presence of primary open-angle glaucoma or ocular hypertension in those over 40, that's nothing to shake a stick at, right? And we know glaucoma, the incidence of glaucoma in the population increases with age, but not to this level. So this is a true increased incidence of the condition. And this is just a graphic representation comparing the two studies. You know what? I'm going to very zip through this genetics because Ian did such an excellent job. Just know that I think the big take home, it's a heterogeneous complex disease, meaning there's a lot of variety. It's not, you've got this disease, you're definitely going to get this type of glaucoma, okay? I'm going to just zip through this. Just to let you know, there's now 20 loci, glaucoma loci have been identified. And you've heard enough about LMX1B. Okay, so I thought I went too fast. I caused seizures, but no, right. The most common form of adult glaucoma is primary open-angle glaucoma. The characteristics: it's chronic, bilateral, vast majority of times, asymmetric, meaning one eye tends to be more affected than the other, just like diabetic retinopathy. Adult onset.